the issue of finances. We all realize that all the 4 bills that became acts that were passed, in our interpretation as the Council of Governors, are money bills. They were acts that were passed and they require money for implementation. And therefore, if there are any gaps in passing the same, because you cannot pass a money bill without providing the requisite resources that are required to implement that, then it is very critical that government at all levels, and especially the Treasury, must provide resources that are required to implement that. Otherwise, rolling out SHA without the requisite funds to the implementing agencies will be tantamount to buying a very beautiful Ferrari with no fuel. And that is why we believe that the government must put all its resources at the moment where it matters. And where it matters is the health of Kenyans. Thank you. We have appealed to the implementers, especially the ministry, to ensure that we increase the bandwidth and improve the system of registration so that it can accommodate the many Kenyans who are logging in to register. Those who are having technical challenges, maybe they are trying to register twice or thrice, it should be able to accommodate that and be able to speed up. The circular has been received from SHA on continuity of the services. We acknowledge that. However, the following challenges exist. Patients who need services for the treatment and management of chronic diseases cannot access services since the emergency, chronic and critical ill covers have not been activated. We are still at the primary level and the shift. But what about those who are chronically ill and they know that from the information you're given, they are supposed to be accessing the service? Do we have a time period which they are supposed to wait despite having an emergency or chronic illness for them to access the service? The social health insurance system is not compatible with the NHIF system. We need to confirm that. Therefore, hospitals cannot claim for services that they offer, despite the circular I gave yesterday, that you can still provide service, but they are not compatible. Our recommendation is a mechanism to allow anyone access the health services should be put in place very urgently so that we do not have that delay. We are aware that the procurement of devices to support the health facility digitization by HMIS, registration claim, that is Health Management Information System. Only 5,000 devices in form of tablets have been procured by the entity Safaricom for registration to be processed. The challenge is there are 7,100 public health facilities. So with 5,000 devices, it means we begin to leave out 2,100. Are they supposed to wait until the other 2,100 been availed for them to make any claims or for them to get sick? Our recommendation here is that all the remaining public health facilities need to be provided with devices to support the claims and registration process.
ICT has a way of not behaving when you need it to behave the most. I have ever gone to make a presentation like what I will make shortly, and then it is only that time that the projector decides not to work. So in this particular instance, Your Excellencies, I am aware that the technical team had invested a lot of effort in ensuring that the systems were ready, not only to register Kenyans, but further to recognize them when they go to hospitals, to record the treatment and submit the claims in ready for payment. That is what I had been shown by a government agency called Digital Health Authority or Digital Health Agency that is indeed coordinating this. Yesterday, we commenced the rollout of universal health coverage, and indeed we call upon all Kenyans to go out and register as a number one. The registration process, I would say, was successful up to about 80–85%. And why I'm not giving it 100% is because it was evident that when many people tried to get into the system got clogged, and some of the registration exercises were not successful.
What is it? What's our primary aim? Is it to create a referral system? Is it to have domestic resource mobilization? Is it to digitize the patient data? Is it to do all these things? Then if it's to do all these things, what's the building block? It is financing. Why are we not very clear on the financing? And then we're also looking for the common thread, the thread that weaves all this together, and we say, for instance, we know when we had a new constitution, we knew the three arms of government, everyone was defined and everyone was doing this. So what is Digital Health Agency doing? What is SHA doing? I have heard the CEO has tried to explain.
On the health facility registration, I want to report that indeed there is a significant progress, and for the first time, we have seen the highest number of county health facilities being registered for the purpose of being in panel with the now Social Health Authority. And we expect that was one of the biggest challenges that the Excellency Governors were asking, how come NHIF then was not paying money to these facilities? We realized there was a challenge in terms of registration and empanelment. The Act, Social Health Insurance Act, specifically gave that mandate to KMBDC that immediately they register, they notify SHA. So it is going to be seamless. I believe the remaining 10%, or 2%, if I go by the statistics here, will be covered because KMBDC have allocated their officers within the regional blocks. They go around all those counties within those regional blocks to ensure that all the facilities that are functional are registered. And this, as per the Act, it required that they pay the full year subscription for those who are in formal sector. That was reviewed, and now they start paying in terms of either monthly deposit or quarterly deposit. So they will be advised accordingly. In the whole program, and which will be done with an immediate effect, is we are going to procure additional 65,000. Meaning, we are not just for the facility. That is one for the billing. We are going to kit all your healthcare workers with a tablet. It sounds not realistic, and it's going to be realistic. All right? The key healthcare staff within the facilities will be issued with a tablet. That's why we're going to procure additional 65,000. On Sunday, an administrative decision was taken that we use the NHIF to identify the patients, because number one, when the patients who are paid up members of NHIF were moved to SHA, we had the right to use the NHIF to verify those those patients that they are fully paid up members, and most of them got their services because they were identified using the NHIF system. The NHIF, the acting CEO SHA is here. He gave directives, and that was done. Initially, there was a problem because I think that information which we made late in the night did not reach the staff in the morning, or all the branches or all the facilities. And therefore we realized that some of the
facilities had switched off the NHIF system, and that's why there was that hue and cry in the morning. But we quickly closed in, we communicated, and everybody was informed. So the financing pillar is under Social Health Authority. That's why you see Social Health Authority coming in because of the financing model, and I think Dr. Kuhora has taken you through. And then we have digitization. This is being done by the Digital Health Agency. Again, that's a new agency that was formed to support in digitization and ensuring that we have the entire health ecosystem digitized, away from the normal digitization process. You are aware also that for the commodity security we have, or the commodity pillar, we have KEMSA. And Excellencies Governors, I don't know if you are aware, that we all discussed the issue of the debts owed to KEMSA, and I think the President gave directives. He talked of that all of us sit down, we know NHIF then, or currently SHA now, owes counties about, is it 8 or 12 billion? All right? That we shall start looking at how and then do we knock off, because you also owe KEMSA 3.4 billion. So any funds that are now going to be released to Social Health Authority will either, after doing reconciliation, and we have directed that we start doing reconciliation, confirming that these are the actual figures outstanding for each county, and then we start knocking off so that it is paid to KEMSA. KEMSA starts supplying you essential drugs. We are still working on the insurance premium finance model to be inbuilt within the system, so that if they want to be supported by their SACCOs, their cooperatives, or any financial institution where they have financial arrangement, they will be able to access that within their funds. So that's being worked on, and I want to tell you that it's on track. Probably immediately we sort out the issue of payment, and then that will follow.
Now, yesterday we were also able to migrate about 9 million Kenyans who are in NHIF, and to send them messages to tell them to confirm the migration by dialing *147#. One of the greatest headaches around registration that we saw was that when someone got queued, you got in the queue, many of us tried again and again and again. So if there was 10 of us trying to queue or to process, because we were trying many times, it is actually possible that at the end of the day about 50 or 70, because we tried many times, there were 70 or 100 attempts. That caused more confusion, and we addressed that by sending messages to the Kenyans who are trying to get into the portal, to tell them we have received, we are processing, relax, we shall come back to you once processed. A lot of this technical information will be provided by Digital Health Agency. When people went to hospitals, and I'm aware that COG controls the majority of hospitals in our country, they were not able, the claims processing system was not able to work as envisioned. So the biometrics were indeed not working. We had patients on dialysis, we had patients that required chemotherapy, we even had mothers that required attention. And what I did immediately, I wrote from wherever I was to all hospitals, and I committed that the government and SHA will be able to settle this, because we are not going to sit and watch Kenyans die. As I was doing that, of course, there is what I can do from a policy perspective and what I can escalate. We were able to escalate to the Ministry of Health, we were able to escalate to our board, and we were even able to escalate to the head of public service what we are going through. And we have a meeting today at 4:30 p.m. to ensure that all these issues that we are experiencing we are able to quickly make a policy decision and move. So to that extent, I want to thank all of you, because whilst we are having problems, the teething problems that come with every introduction of a new thing, we are standing together and we are continuing to see patients where we have to see them, and we are not letting any Kenyan die because of something technical.
One of the health financing issues that has been brought up by Mutahi Kango in regards to what is available versus the realistic amounts that will be needed by counties, depending on the registrations and the contributions of our citizens, we still need a lot of IEC materials to go out there, a lot of communication, and a lot of reach out to both the informal and the formal sectors. Other issues were raised was the 30 billion owed to counties, when will that be paid? And for the indigents, I know a lot has been given to the counties, and there are some counties with very small lean budgets. Where will they get that funding to cover the indigents? Not only covering, but even their identification process, the synergy between all the ministries. I know there'll be the Maisha number that will come, that will make these processes better. But those are things that should have come in the forefront. There should have been more synergy with KRA and social services, and how we captured how the payments will be done and how they will be delivered. There was the issue on the repayment of the digital health products, which we do appreciate the holistic approach, because it is a heavy investment and counties have been given, but with the FIF, where we have appropriation in aid, how will we pay that based on the services that we will be given? The reality of also the timely disbursement of funding. The timely disbursement of funding will also be a challenge, because if you look at what we had, the user fee for gold, some counties were getting only 18 million, but if everyone registered, like giving the case of Nadi, everyone registered, and we have the private and the public, we would be getting an additional like $500 million, but will that funding really be there? One of the issues also was the chronic and emergency services, the funding that is available. I remember in one of the meetings where a quotation of about 45 billion was placed out there, and we questioned on that. We looked at the cancer patients who will need 85 billion. So the numbers for planning versus the reality of the funds available, we must be very careful to win the confidence of our citizens by promising what we can really deliver. And Treasury releases, we do have the enabling ministries like KEMSA with the refill rates, and also paying for the pending bills. If we get Treasury to have the timely releases, then we will be able to provide the services that we are promising our citizens.